Welcome everyone to our Access California May podcast. My name is Stephen Thomas. I am the Access Program Advocacy Director with Cal Voices, and I'm here with Claire. Claire, introduce yourself.
Hi, I'm Claire Courtwright. I'm the Policy Director for Cal Voices. Access California is a program of Cal Voices. And I'm a person with lived experience of serious mental illness, as well as most of the staff here at Cal Voices. And so the Access program, which is new to us, is a program to uplift the peer voice and lived experience, those of us who have these illnesses and have navigated life with them. How's that?
That was great.
Was that good?
That was great. We are here today to kind of talk a little bit about the elephant in the room with the passing of Prop 1 in March. And you'll probably hear this sort of narrative and dialogue over the next coming months as we start to see things becoming more and more implemented, and counties are starting to sort of buy in to the Prop 1 changes. So first, we'll talk a little bit about what Prop 1 is, and we'll just have a conversation from there. Claire, can you tell us a little bit about Prop 1?
Sure. I think people probably haven't heard a lot about it. It was a ballot initiative, so it was. We had an election regarding it during the primary election on March 5th. And it narrowly passed in the state. And it was a combination of two bills passed by the legislature, but they also needed voter approval. So the legislature, drafted what was in them, and then the voters adopted it. So it was SB 326, which makes some pretty massive changes to the Mental Health Services Act, and AB 531, which was a bond. So the state of California is going to borrow some money to build some permanent supportive housing and a lot of new clinical treatment beds for mental illness and SUD. And since I know you're newer to the topic, Stefan, what's the first thing that comes to mind that you would want to know about how the peer community feels about what's happening? Because Prop 1 is not riding alone. It's part of a very large number of new laws in the state of California relating to mental illness and substance use disorders.
Well, I think, as a consumer myself, who has recovered from, mental health challenges as well as substance abuse disorder challenges, someone like myself who has, sort of worked in the field for, almost a decade, there are certain things that I know, but you'll hear, you all will hear things like MHSA. You'll probably hear things like BHSA. Prop 1 is another term that you'll hear. And I think, if I didn't have my experience, I would want to know what MHSA is to begin with, and what's so big about Prop 1 that changes it.
Yeah, that's a great question. And it's, and why is it that people with mental illness care so much about this? And also folks with SUD should too. The Mental Health Services Act was a homegrown thing by the disabled community. It was back in 2004, so almost 20 years ago. Wow, it was 2004 20 years ago? It was a grassroots voter initiative. So California is kind of cool because you can do direct democracy stuff where you can just put something on the ballot if you get enough signatures and do it, just like you're the legislature. So that's what happened. It was a law that was crafted by Rusty Seelix from Mental Health America, and Daryl Steinberg, who was in the assembly at the time, but it did not go through the legislature. And it was this idea to have a new model of funding and services for people with serious mental illness that would be delivered at the county level. And it was supposed to transform the mental health system, because really all our folks ever had was Medi-Cal. And it's like, how much does your health insurance really do for you? I mean, if you have a really impactful disability, depending on how much it's impacting you at the moment, it's like, is your health insurance really doing that much for you? And it wasn't doing that much for our folks. And there wasn't another source of funding from the state. There's just not a lot of money actually coming from the state directly to serve, provide programming for people with serious mental illness. So they wrote this law and they wrote it with the community. Literally, they had public meetings, like real stakeholders were there. The thing was amended a bunch of times. Like they drafted up. It's actually super genius. I'm an attorney and I'll nerd out on this. I'll be like, dang, this was really good. Um, but basically, basically, what it did was the voters directly taxed some millionaires. They put a tax on incomes over $1 million, a 1% tax, and that money went to the counties. It went to the state, and then it was distributed by the counties so that the community could build their own system of care. And what was special about it was the community planning process. So the counties were required to go like engage people in the community for what kind of programs and services do we need here in our local and unique community, because LA isn't like Shasta and California's a big state. So it was really kind of genius, and it really has been a success. And there's all kinds of programs and services that you will not find funded by health insurance that have been funded through the MHSA. So like here in Sacramento, we have the mental health urgent care clinic. It's the only thing like it for counties around, right? Like it's 24/7. You can walk in off the street with no insurance, with no money, no copay, and see a psychiatrist or a licensed marriage and family therapist, get a peer support worker who's another person with mental illness or SUD to help you. And these services are free. And I mean, that's incredible, right? To not even need insurance and be able to walk in off the street and receive healthcare. That's kind of unheard of. So that was the MHSA. And it was supposed to be services delivered, designed by the community and delivered by the community. So it wasn't these big, Kaiser, Sutter type providers. It wasn't these things that become, so corporate. It was community based services, community based organizations delivering them, people that are from your town. And it had a heavy focus on being culturally competent, in all the ways, in all the facets of our our identities. And so it was really a beautiful thing. And there was a lot of hope in the time at the community that it would be transformative. And, it really too, because I mean, if you have a serious disability, there's not much of a social safety net.
No, not at all.
No, I mean, there's like, you're really kind of not in a good situation if you can't work. We don't have a law that says, if you have a disability and you're unable to work, then the state has to pay to house you. We don't have a law that says that. So
just not a lot of protections.
No, and not a lot, even if you work, not a lot of protections. So we have folks who they're impoverished. They're impoverished because of their disability. They don't have a source of like income. They don't have a source of housing. They may not have appropriate housing. And the MHSA really filled a lot of gaps. So it's like the number of things that it was doing, it was like Section 8 for people with serious mental illness. Yeah, you want to talk about that?
Subsidized housing. A lot of referrals came through the coordinated entry system and related to, FSP full service partnership programs. And a lot of those FSP programs not only were able to get subsidies using MHSA funding, but could also furnish apartments, provide food stipends, transportation stipends, where otherwise, enhanced care management may not be able to do that, or managed care programs may not be able to do that. So there was a lot of support, especially around permanent supportive housing and housing in general, using MHSA funding. Now, I can almost hear it. I can almost hear the but coming when it comes to Prop 1. And you mentioned SUD. For those who aren't aware, SUD is substance abuse disorder. And currently, some of those changes are starting to include treatment to substance use disorder with that change of MHSA to BHSA. Is that right?
Yeah, you got it. So, yes. And I think everyone thinks that's a positive thing. So, right. So what did Prop 1 do? I was kind of telling you the MHSA is great. It is great. Prop 1 fundamentally changed it. And I think for the peer community, the people with serious mental illness, the ways in which it has changed are mostly awful. I mean, that's the attitude of the peer community, because we're going to see a lot of the things we love cut, right?
Right.
So what did it do? It took all this funding, about $2 billion a year, and the counties would get 90% of it. And then there were broad categories in which they could do whatever programming the community wanted. So what the state did was really take a lot more control over it and take it out of the hands of the counties. And then it took that pie, and it didn't make the pie bigger, but it cut the pie up differently. So, the SUD community was mostly in favor of Prop 1 because it allowed Mental Health Services Act money that previously was restricted to be used for serious mental illness for adults and children. And it opened it up to moderate to severe substance use disorder. And everybody in the mental health community was in favor of that. But we wanted more funding, right? We didn't want there to be a fight between we didn't want it to be not a fight, but we didn't want there to be scarcity. We didn't want a scarcity model where it was like, oh, if we're going to fund, some innovative outside the box, not medical insurance services for substance use disorder, we don't want that money for that programming to be taken away from, the mental health urgent care clinic or the the Sacramento County respite program for foster families that have taken in children with serious mental health needs, right? We're robbing Peter to pay Paul is kind of what they were saying. So that was the good thing is that yes, SUD should have a source of funding that isn't just health insurance, but they refused to raise the MHSA tax. So now what's happening is, because of the inclusion of SUD and because they required that counties shift about, out of that $2 billion, about $719 million is shifting out of what we call community services and supports and into housing interventions. And so there too, people are like, oh, it's kind of robbing Peter to pay Paul, but housing is good. But so much of this is we're not really sure, right? We don't really know if it's going to go towards permanent supportive housing or if that money is going to flow into institutionalization, which means you're under some kind of court order, like a conservatorship or care court or AOT, and that court order is saying you have to live in a clinical treatment facility. Who's paying, right? So the concern is, is that quote unquote housing money going to be, a place where you can live forever, and it's not clinical treatment, it's a home. Or is it going to be time limited and court involved clinical treatment facilities?
I'm hearing something interesting, right? Because, I do have some experience working within, permanent supportive housing and the supportive services lens, but I'm hearing something interesting around SUD related clients and the potential of it not going to permanent supportive housing. And you mentioned it briefly when speaking about potential hospitalization. Can you kind of just dive a little bit more further into that? I'm very curious about what that might look like.
Sure. And that's a big, speaking from the peer perspective, that's a big concern, right? We don't want our money for voluntary services flowing into the involuntary system so that people can't even access care until they end up in an involuntary situation where, you have to go to an emergency room and you end up in a psych hospital because you can't access outpatient care and you're decompensating, or you just can't access the supportive services you need. So you end up in jail. And that's not a place you want to be with a mental illness. So, there's a real concern about the lack of access that can happen. And right now, because the Mental Health Services Act was made by people with mental illness, one of the very important things about it was we were like, we don't want this going to law enforcement. So it's written into the statute. It cannot be used for any law enforcement purposes, right? So you can't just steal it to say you're providing mental health treatment in a jail. You can't use it for long-term institutionalization. So those long-term, when we're kind of saying it's treatment, but you've been there so long, it can't possibly be treatment. If you're stuck in a state hospital for 40 years, what treatment are we engaging in that we think is going to change the baseline situation, right? At some point, you kind of have to give up the ghost and be like, we're doing the old school thing where we lock you in a building for the rest of your life.
So we're talking about quality of treatment. and how that
Absolutely.
might be potentially impacted by
You
these
got it.
changes as well.
Absolutely. Yeah.
Okay.
So right now, the MHSA, like I said, no law enforcement, cannot be used for long-term institutionalization. It can be used to pay for a short-term involuntary hospital stay if there's no other insurance payer, which would be very rare for someone to not, qualify for Medi-Cal at this, or ACA at this point. So really, it was protected against being used, but the court system has tried to chip away at it, and there's been some legal fights over it. But basically, Prop One really kind of reset the stage, and it let the state, through the Department of Healthcare Services, decide, what it's going to do with this money without the community, and potentially kind of decimating an already almost not accessible mental health system on the voluntary side.
Okay. And so moving further into substance abuse disorder related clients, um, how are they impacted directly? Let's say there is no comorbidities, which
Mhm.
sometimes with substance abuse, there is mental health comorbidities. Let's talk about treatment with some of these changes. Are we talking about optional treatments that agencies, or are they required to provide these treatments? What does inpatient substance abuse treatment look like with
Yeah.
some of these changes?
So that's a great question, and I know in your mind, and I should spell out that you're bringing together several threads because there's several things going on in addition to Prop One. So what also happened last year, straight through the legislature, didn't need to go to the ballot, was for the first time in California, any type of substance use disorder, if it's severe, so any type means any type of use of substances, right? So the substance could be marijuana, it could be opioids, right? Um, so any severe substance use disorder, you can now be put on involuntary holds, put, in a facility against your will, just like mental hospitals, and also conserved. And conserved means you're under a long-term court order that can place you in a locked facility long term. And long term means a year for the initial order, but they can renew it without end, even though you're currently sober because you're in a restrictive environment. So obviously, we had super big concerns about that because my community's experienced it, and the SUD only community hasn't yet. Um,
Okay.
so with Prop One, if they don't change, we want them to not change the regulations and keep the requirement that these are for voluntary services. But we know that the court ordered stuff doesn't have a source of funding. So it's very likely that, this new schema of sort of, you know, the mental hospital system, but for severe substance use disorder, it needs funding, and where is it going to get it? So we think that it's highly likely, given the state's budget deficit situation and everything, that this money that used to be only for voluntary services will flow into the court involved system, the court ordered system. And, related to that too is the other part of Prop One, besides the Mental Health Services Act money, now called Behavioral Health Services Act, or BHSA, was this bond, right? So we just think the state is borrowing $6.38 billion, and two-thirds of that is going to build clinical treatment facility beds. And at the 11th hour, they stripped out of the bill, they gutted and amended the bill and said it used to say it was going to build only voluntary and unlocked treatment facilities, and they stripped the language and they allowed it to build locked facilities, and they didn't say how much of the money was going in which direction. And I think people, and the estimates change, but I mean, the state sort of says different numbers at different times, but something on the order of 6,000 beds. And so it really matters whether they're locked or not, because the mental hospital, just mental hospitals, not the long-term locked like state hospitals or what we call IMDs, where conserved people can be locked up for a long time. But just the normal mental hospital system is somewhere between 6,000 and 7,000 beds in California. And we don't have good data that has been updated, but the estimates are, you are impacting hundreds of thousands of people a year just with that number of beds. And so, we're looking at this like, where's this going?
And that impact is whether it's locked facility or unlocked facility. And then, of course, what is the impact or potential outcome of you know a positive outcome or successful outcome, if you will, of substance abuse clients' treatment in a locked facility versus voluntary, voluntary treatment?
Well, that's a better question for Stefan. Do you think that locked SUD treatment works? I mean, no, I mean, some of this is right. We're trying to tell the community what is happening, but also like where we can go with advocacy. So we
Right.
know we're building a lot of beds. We know that, I mean, it doesn't sound like that many, but when you look at the number of beds that we have in California and how many people are impacted by them, this is a massive increase in the size of the system. And obviously, we did not, have like the peer community did not have a problem with this bill when it was promising that all those mental health and SUD beds would be voluntary and unlocked. Nobody had a problem with that. But when they put in the locked language, then we were like, what are you doing? So, in terms of advocacy, I am identifying some opportunities. And if you follow the Access program, you'll get more information. But there's a lot of opportunities, even though these laws have passed, there's so much that's unformed and unwritten about them still. And we know who the players are who get to write it. And so one of the places for advocacy is really what will these programs build? It's called the Behavioral Health Continuum Infrastructure Grant Program. What are y'all going to build? We don't want you building more locked beds, especially, if you're familiar with like rehab beds. How short are we on voluntary rehab beds, Stefan?
In some cases for the county, 2 to 3 months, sometimes 4 months of a wait list just for county. And then otherwise, out of pocket payments of upwards 30 grand a month for treatment, right? So accessibility for rehabilitation programs is very sparse.
Yeah, exactly. So, I mean, I think that's a way in which, this could go in a good direction, right? If that bond money went to build genuinely voluntary, not court involved, unlocked, accessible, that could be positive. I mean, you see what like free, accessible, non-insurance required mental health treatment. It's like a dream, right? Like
Yeah.
the mental health urgent care clinic in Sacramento is a dream for a model for accessibility for folks, right? And you don't have to have any form of money. You don't have to be a citizen. You know what I mean? It is really, an immediate access. And imagine if that were actually available on the SUD side. Like imagine if there were a place that were non-judgmental and welcoming and positive and staffed with people with lived experience and the kind of love and wisdom that comes with that. And you could just walk in off the street and say, I want to be in this program. I mean, imagine that,
Yeah, I think the outcomes would look a little bit different than if it were, in a locked facility. I imagine that if there were mental health comorbidities and you were locked in a facility, just because you might have had a day of where there was a relapse or any sort of activation, or maybe you're having a mental health crisis or anything like that, and it's related to substance use, and suddenly you find yourself in a locked facility. I feel like there's a chance that it could actually exacerbate some of those challenges rather than the same healing ability if you were able to walk into these places voluntarily seeking treatment.
Yeah, and I think that's unfortunately that's the experience of so many members of our community. It's not that people think that they didn't need help or they don't want help. It's that when the involuntary system got involved, they got run over and they got horrendously traumatized, and it damaged their lives. And so, for the peer community, we're sitting in this place where we can't understand why it should be controversial that the North Star should be that we eliminate any violent or carceral response to disability or substance use disorder, right? That how you get there might be a question, but those are our values.
Yeah.
And we feel like when we look around the state of California, those are not the values that are driving these policies.
Right.
And so that needs to change. I think sometimes what you hear from folks is not necessarily that they think that violent and carceral responses are ideal, but they think that they're necessary, and you need to question that.
I completely agree. And I want to roll back just a second because you mentioned, right? We know that there was a narrow passing of Prop One, right? So it is going to be in place. Um, just how soon would we see some of these changes, this implementation? And then moving even further, how can advocates like us, like you all, peers like us, like you all, what can be done about it?
I mean, that's a great question. In terms of how quickly are these changes taking effect? Too quickly, honestly. To bring online an entire, imagine if you tried to create the entire system, that exists, the mental hospital system that exists, the regulatory structure, all of it. Imagine if you tried to do that in 2 years, right? Because that's really what they're trying to do. So, two counties have already said, yes, this new, ability to just pick folks up off the street with a substance use disorder. There's two counties that have said, yeah, we're gonna try to go for that right now, San Luis Obispo and San Francisco, but I don't think they've actually placed anybody on a hold because the facilities don't exist, the regulations don't exist, the safety treatment aspect of it. I'm not sure the state even really knows what it thinks SUD treatment is. And trust me, it barely has an idea when it comes to mental illness. But
Right.
but there's so much that's unformed, but it's also coming too quickly, right? And I think there's a real desire because what's driving policy is not let's improve mental health, let's improve the mental health system, let's talk to the customers and improve customer service. That's not what's happening. What's happening is there's a very wild and increasingly sort of urgent call from politicians to do something about the unhoused and the perception that the unhoused are sort of largely, if not exclusively, persons with untreated mental illness or SUD. There's very good data to suggest that's not remotely the case, but there's enormous political pressure and a sense that this has to change right now. But the BHSA, the funding allocations to the Mental Health Services Act, those technically take effect January 1, 2026, but the counties have to completely pivot. And so you're going to start seeing those really deep cuts to county programs almost immediately, probably, starting after the end of this year, after December of this year, you're going to start seeing, folks get laid off and programs close that infrastructure really get impacted. That outpatient treatment infrastructure, that I've given some examples of, get really impacted. And then, in terms of SUD and how soon will we have locked SUD, it really depends on the buildings a lot. And so I think what you're seeing is this kind of slapdash idea that, okay, we're just going to take people with SUDs and put them in mental hospitals, or we're going to put them in mental health rehabilitation centers, or we're going to put them in skilled nursing facilities. I mean, and I'm not making that up. There's a bill, right? Like those types of facilities.
Right.
But I mean, there's really an inclination to do this fast and too fast.
And so the reason why we covered so many different topics around this today is because we're going to actually have future conversations that are going to be rapidly becoming available to you all as we start to dive more and more into some of these implementation related changes. But that is our time for now. But stay tuned. We'll talk a little bit more about SUD treatments and how it pertains to Prop One. We're also going to talk a little bit about some of the unlocked facilities and how some folks in LA have been in hospitals for over a year. And so we'll have a conversation coming soon on that. But in the meantime, if you are not subscribed to our Cal Voices YouTube channel, like and subscribe, and also sign up for our newsletter because we will be putting out, Access California will be putting out quite a lot of content very, very soon. So thank you for sitting with us, Claire. Thank you for letting me pick your brain and ask a lot of really silly questions.
That's there's so much going on, honestly, that it does become kind of overwhelming, and it's best to take it in bites and take it from the perspective of the people that are receiving services or voluntarily or involuntarily, and the impacted folks.
Yeah, and it, we'd love to hear everyone's experience. So if you like, reach out to us at Cal Voices, and Access California, access at calvoices.org. And we would love to be in touch. And thanks again for being here with us today. Thank you so much, Claire.
Yep. See you next time.
Bye, everyone.